Okay. So we are going to talk about rheumatoid arthritis. Everybody can hear me. Yes?
Yes, madam.
Okay. Right. So this is the outline of my talk. I will explain to you what rheumatoid arthritis is and then talk you through the pathophysiology of rheumatoid arthritis and then explain to you how to assess the patient, to diagnose and to investigate, then focus on the treatment and then give my conclusions. You all have already done the lecture. Have you all done the blood and lymphoreticular module?
Yes, madam.
You have. So I did a lecture on immunological arthropathies. Yes? No?
Yes, madam.
Okay, right. So I dealt with the pathophysiology there as well. So I'll be speaking about the pathophysiology very briefly. So what is rheumatoid arthritis? So to explain this better, I'm giving you a case history. This is a 24-year-old person who comes with multiple joint pains in the hands, wrists, the elbow, shoulders, knees, ankles, and feet. She has had this complaint for 8 weeks, and there is a significant early morning stiffness, and she can't bend her hands until about 10 o'clock in the morning. She gets up at about 4 o'clock to cook food for her family, but she just can't manage to properly bend her fingers, so she finds it very difficult. On examination, multiple metacarpal, metatarsal, and proximal interphalangeal joints in both hands and feet are inflamed. Both wrists, both ankles are also inflamed. The rheumatoid factor is strongly positive, and the anti-CCP antibodies are strongly positive. The clinical diagnosis then is rheumatoid arthritis. Can someone tell me what I said about the specificity of the rheumatoid factor and the specificity of the anti-CCP antibodies? Anyone? Can someone please answer? Because I feel like I am a psychiatric patient speaking to a blank screen. Yes? Anyone?
Rheumatoid factor, it can be positive in other conditions as well other than rheumatoid arthritis, but anti-CCP antibodies, it is more specific for rheumatoid arthritis rather than rheumatoid factor.
Right. Perfect. Brilliant answer. Good. So this patient most likely has rheumatoid arthritis. So just like what she said, the rheumatoid factor is positive in about 70% of people who have rheumatoid arthritis, and the antibodies also positive in about 70 to 80% of people with rheumatoid arthritis. But if you have an anti-CCP antibody, you're more than 90% sure that you have rheumatoid arthritis. Have you all seen patients with rheumatoid arthritis in the wards? Have you seen? Not seen?
Yes, madam.
You have seen, right? Okay. So when when her hands were examined, they looked a bit like this. Can someone tell me if they see any abnormality in this hand? Anyone? Anyone? Does it look normal?
The interphalangeal joints of both hands are swelled.
Yeah, they are swollen and they are looking like spindles. You have seen the muscle spindle. So a spindle is a weaving a loom of thread. So the weaving thread is like a spindle. And if you look at this hand, and now my cursor has vanished for some mad reason, the hand is showing spindling, right? So the clinical diagnosis is rheumatoid arthritis. So what is rheumatoid arthritis? arthritis. Rheumatoid arthritis affects multiple joints of the body. It particularly affects what we call the small joints of the hands, the proximal interphalangeal joints, and the metacarpophalangeal joints, and the same in the phalangeal joints. The joint symptoms and inflammation is roughly symmetrical. That is, it tends to occur in similar areas in both sides of the body, and they are inflammatory, where the patient says that they find it very difficult to get up in the morning and to get moving. They have significant early morning stiffness, which lasts for about 1 to 2 hours, right? Some of my patients say they are stiff until about 2 o'clock in the afternoon, though they get up at 5 o'clock in the morning, right? So you suspect rheumatoid arthritis in a patient if they complain of joint pains, particularly in the hands and feet, and if there is early morning joint stiffness which lasts more than 1 hour, there is symmetrical joint involvement, and you press the joints, there is pain, and the symptoms are there for more than 6 weeks, and if you have elevated inflammatory markers, an antibody is positive. So the problem with rheumatoid arthritis is that the problem starts in the synovial lining of joints, and without the, I don't know how I am going to get my cursor back. Okay, sorry. Anyway, if you look at the diagram on the right hand side, you will see that the synovial membrane is thickened, and there is increased production of synovial fluid. And because of this inflamed synovium, the cartilage and the bone are getting eroded. So what causes rheumatoid arthritis? So if you think of the pathophysiology of rheumatoid arthritis, I'm not sure whether this was done. The synovial membrane is inflamed and thickened, and then it eats into the bone and cartilage. There is loss of cartilage and bone, and ultimately the body, which is very efficient, heals itself by fibrous ankylosis, and ultimately there is bone formation and the bones get fused, and that is called bony ankylosis. So basically your body moves from what we talked about earlier, where you get just spindling of the joints, to severe deformities. I showed this diagram to you during your immunological arthropathies account only for about 60% of the worried if they are rheumatoid. 6 is due to other factors, right? Like a poor diet, poor dental hygiene, and thereafter there is post-translational modification, loss of immune tolerance, and an autoimmune process is initiated, and you get raised cytokines, chemokines, and inflammatory markers which initiate the autoimmune disease. So you have been told earlier as well that smoking, microorganism stress, and the genotype are important, and you go with a pre-articular or a lymphoid phase, and then that moves on to a articular phase. The other thing which is very important to note is that the cytokines in rheumatoid arthritis cause fatty liver, stress, depression, reduce bone mineral density, insulin resistance, and increase atherogenesis. But the articular manifestations are the most prominent in rheumatoid arthritis. Can someone please describe what is going on in this hand? Just a description. I'm not interested in technical things. I just want you all to participate because I can't see you and I'm getting really bored talking to myself. I'm waiting.
There is hyperextension of both hands. We can call it a swan neck deformity, and there are rheumatoid nodules in interphalangeal and metacarpophalangeal.
And you can see that there is ulnar deviation of the fingers and the radial deviation of the wrist, and that it is very symmetrical, right? You can see that the metacarpophalangeal joints are practically jumping out. So they have basically subluxed out from their new earlier articular place. Okay, so these are the typical deformities that you see. You see boutonniere or buttonhole deformities in the thumb and in the fingers where there is hypophalangeal joints, or there is a swan neck deformity, of the distal interphalangeal joints, or there is a swan neck deformity where there is a flexion of the distal interphalangeal joint and the opposite movement of the proximal interphalangeal joint. Rheumatoid nodules can occur in extensor surfaces, and in the toes, you can see hammer toes where the toe is out of alignment, hallux valgus where the big toe is moving closer towards the other toe, and the metatarsal jumping out to the medial aspect. If you look from above at the hand, you will see weakened muscles and wasting of the dorsal interossei, and you will see the ulnar drift of the fingers. If you look at the hips and the knees and the feet, similar problems are there, and you will see in the can anyone tell me what they see in the left hip x-ray based on your normal anatomy knowledge? Anyone? Anyone? In the hips? I'll take you through. I just want somebody to respond. Somebody, come on. I have a lot to talk about. Anyone? Are these normal hips or not? Can somebody tell me that? Yes? Is the batch rep not here? Can somebody please speak and so that we can get some participation here? Yes? Okay. What about the hips?
The articular surfaces of the hip joint is more prominent.
Yeah, so you're correct. The articular surface is very prominent because the bone density is very low, and it looks like the articular surface is almost penciled out. Very good observation. The joint is very is virtually non-existent. There is no joint space, and the hips have basically almost moved. In terms of the knee, this is difficult for you to notice, but if you are the knee which is on your left hand, has a valgus deformity, and the right hand picture shows hammer toes, bunions, and hallux valgus and spreading of the forefoot. Okay, so those are the kind of things. The very most dangerous thing is that you can get cervical atlantoaxial subluxation, because the pannus formation in rheumatoid arthritis happens in the cervical spine, and the odontoid process moves in front, presses on the spinal cord, and you can get paraplegic. Rheumatoid arthritis causes multiple extra-articular manifestations. In the eyes, you can get scleritis, scleromalacia, you can get dry eyes, dry mouth. In the lungs, pleural effusions, inflammation of the alveoli, Kaplan syndrome, which is a condition seen in workers' pneumoconiosis. You can even see rheumatoid nodules in the chest X-ray. You can have anemia, you can have nerve compression, nerve inflammation, splenomegaly, leg ulcers, peripheral neuropathy, right? So many things can occur. And if you get any of these patients for a long case, you need to check for this. So on the left-hand side in this picture is a picture of Felty syndrome, where you get splenomegaly, poorly healing leg ulcers, leukopenia, neutropenia. And on the right side, you get scleromalacia, where the sclera has got damaged and there is severe damage, which is shown on the blue, in that blue area. So rheumatoid arthritis is divided into early arthritis and established arthritis, right? The reason is that we need to identify patients who have early arthritis. Earlier, when I was a medical student more than 25 years back, we used old criteria which depended on the presence of hand deformitors, and then it was the arthritis had to be really long term, really established, and the immunological cascade was really established for us to diagnose rheumatoid arthritis. But we know that we must diagnose rheumatoid arthritis early, because we have a window of opportunity to treat this. So it is like you going for your final exam. You can't prepare for your exam in the last 1 year. You have to work right throughout the 4 years, because otherwise you have lost your window of opportunity to learn. So it's like that. If you have got established rheumatoid arthritis, where the immunological cascade is fully established, then it is very difficult to treat. And studies have shown that if you treat rheumatoid arthritis early, prevent joint progression, and you can reach what we call a remission, where the joint disease is completely settled. So how do you assess a patient with rheumatoid arthritis? First of all, you need to confirm that the patient has rheumatoid arthritis. Then you need to assess disease activity. Then you need to check the patient for any complications of the disease or for any contraindications to disease modifying drugs. These are the ACR-EULA classification criteria for rheumatoid arthritis, and these are used to diagnose rheumatoid arthritis very early when there is only joint pain and inflammation. This is in contrast to the old classification criteria, which are probably older than you, where you needed deformities, damage, X-ray changes, rheumatoid nodules to diagnose. So if you diagnose patients as having rheumatoid arthritis using these criteria, you would have missed your window of opportunity to treat. So this is an X-ray again to show you the difference between early arthritis, that is on the left of your screen, and established arthritis or end-stage arthritis on the right of the screen. In early arthritis, you see soft tissue swelling, joint space narrowing, and periarticular osteopenia. And you see tiny rat bite-like erosions. In established arthritis, as I mentioned earlier, the bone is all weak and there is osteopenia, and the carpal bones are fused and ankylosed, and the joints have got damaged and they are disarticulated and they are subluxed out, and there are multiple erosions. After you diagnose rheumatoid arthritis, you need to assess disease activity. If you have high cholesterol, you can use the lipid profile to guide you as treatment. But in rheumatoid arthritis, the rheumatoid factor does not change with disease treatment, and so you can't use that to guide. The ESR also changes in some patients, but not in all. So we have what is called a composite disease activity assessment to figure out whether the treatment has worked or not. So on the screen is something called the DAS 28 disease activity score for 28 joints using either the ESR or the CRP. So what I do in clinical practice is I see this patient, and if I need to make a treatment decision, I enter this information on my phone onto the app, and it will give me a disease activity score. So there are the thresholds of disease activity scores are there, and if you have a DAS 28, it is less than 2.6, you have achieved your treatment target. If you have a DAS 28 more than 3.2, you need to improve the treatment. Can somebody tell me what kind of investigations I will need to do to assess if rheumatoid arthritis has affected other organs? I showed you some pictures, but can someone tell me 1 or 2 investigations you might want to do as part of the assessment? Yes? Anyone? Y'all can hear me, right?
Chest radiographs.
Can you all hear me?
Yes, madam.
All right. Nobody is answering the questions. I am getting very disheartened. Can anyone tell me an investigation they can do to assess any other organ system involvement?
Liver profile?
Very good. If the liver functions are elevated, either due to chronic inflammation or due to fatty liver disease, then we will not be able to treat. So that is to assess for treatment. Any other thing? Any other thing?
Imaging modalities like X-ray.
Of course. So you are going to do the hand x-rays and look for level of disease activity. But another x-ray maybe you would like to do, or what region, please?
Chest X-ray. ma'am.
Chest x-ray, yes. Particularly if you want to check for if you have long-standing lung disease, and when you examine, if you hear fine end inspiratory crepitations, then you should do a chest x-ray to check if there is rheumatoid lung. You can also do a chest x-ray if you're a smoker or if you have chronic lung disease to check if there is lung damage, which might prevent some disease modifying drugs being used. Somebody mentioned cervical spine x-ray. We don't routinely do it unless there is some symptom to suggest that there may be neck issues. What we do is, if there is any symptoms to suggest that there are neck issues, or if there is increased reflexes in the upper limbs and lower limbs, then we do better to do a cervical spine X-ray, but our definite investigation would be a MRI scan. So what are the drugs that we use to treat patients with rheumatoid arthritis? So the mainstay of treatment are 4 conventional synthetic disease modifying anti-rheumatic drugs. Okay, and we need to start treatment very early, watch the patient for about 3 months and escalate treatment. Rheumatoid arthritis is a multidisciplinary thing. And so in addition to drug treatment, you will need to do rehabilitation, physiotherapy, occupational therapy. You might need the help of a podiatrist. You definitely need the help of the family doctor, the rheumatologist. And in other countries, there is someone called a rheumatology specialist nurse, and that's the person you call if you want to contact the doctor. So, and sometimes you need counseling, you need social worker support. If you're heavy, you need to see a dietitian, you need exercise, you need the pharmacist. So many people come together to treat. Fortunately, there is good treatment for rheumatoid arthritis. But though I say this, even yesterday I saw a patient, today, I don't know, a 20-year-old girl with severe rheumatoid arthritis deformities, who has not come for conventional Western medicine, but has gone for Ayurvedic medicine. The poor girl's hands are like this. She's a A-level student. I don't know how she's going to write the exam. So why do people seek alternate treatment modalities rather than Western medicine? Can someone tell me? Yes? Anyone? Your answer is probably correct, whatever.
These medicines take long time to act.
Yes, that is the biggest reason. Our medicines take long time to act, and it takes about 3 months for the full effect of methotrexate to be felt in your body. And if I am a patient, that is really too long. So we have to combine the disease modifying drugs with steroids to give a better effect. Some people use non-steroidal anti-inflammatory drugs, but steroids have been shown in studies to have a better effect and to promote remission more. Any other reason why people go for Ayurvedic medicine or alternate medicine rather than Western medicine? Anyone? I'm not talking, there are very many types of Ayurvedic medicine. The genuine Ayurveda is very good, but there are lots of quacks who crush in steroid tablets into herbal concoctions and give it to patients. But so people are getting really confused. But what drives them to Ayurvedic medicine? What is the other reason? You need to know this, because otherwise you can't treat your patients properly. Yes?
Fear of side effects.
Fear of side effects, absolutely. There is a feeling that people think that chemicals are dangerous and natural is good, though the greatest poisons in the world are actually in mother nature and from plants and insects and these things. There are, so they that problem is there. Then there's another reason. Very good. Any other reason? So one is the long time to act. The other one is the fear of side effects. And the third one?
These are expensive drugs.
Actually, Ayurveda is much more expensive than Western medicine. You ask people, when you actually factor in, they are paying about 12,000, 14,000 for the month in Ayurveda, but it's actually because of they do feel, like you said, that it is cheaper, but it's actually because they promise a cure, and we promise control and cure for only 30% of people. Like the government and Chanda Porondu, they promise some things which they cannot deliver. right? Like that my poor 18-year-old girl with all deformities, bent wrist, bent elbow, cannot brush her teeth, cannot wash her back. That kind of person is there because people have promised more than they can deliver. But I need you to tell people, I need you to tell patients, I need you to tell family that rheumatoid arthritis can be treated well in Western medicine. Not that no drugs, but it can be treated well. So we have the conventional synthetic disease modifying agents, and then we have targeted synthetic DMARDs, which are called Janus kinase inhibitors. They are quite expensive, maybe about 4,000 before dollar crash per month. But can anyone tell me what a JAK molecule is in inflammatory pathways? Anybody? Anyone? Immunology module has been done. So we have the conventional synthetic disease modifying agents like methotrexate, sulfasalazine, leflunomide, who work, they make their action by affecting lymphocyte function and proliferation. Then we have the biological disease modifying agents which interfere with cytokines like anti-TNF, right? Or we have the B cell depletion drugs like rituximab or tocilizumab or abatacept, which interfere with cell-to-cell signaling. But what is a Janus kinase? Anybody wants to tell me? Try, so that I don't feel bored and feel that you have left my lecture. Anyone?
The tyrosine kinase receptor.
It is a Janus kinases are intermediate pathway molecules. Yes, so they are like tyrosine kinase receptors, but you can look it up for the next time. So basically the JAKs are molecules which interfere, which are important for cell-to-cell signaling intracellularly, right? But because those drugs are very, very expensive, and methotrexate is always the first line drug. It has been used for more than 20 years and it works very well. We use it in juvenile idiopathic arthritis in 2-year-olds, and it is very safe if you monitor the patients. It has got a bad reputation, but then everything which has a good reputation is not always good. It is has a bad reputation only when it was used in very high doses in cancer therapy. We use what is called a low dose drug treatment. I think the pharmacology team will talk to you about leflunomide, hydroxychloroquine and sulfasalazine, and most definitely I will be doing a lecture on therapeutics. But at this level you just need to know that there are certain conventional disease modifying drugs which I have named here, and that methotrexate is the first line drug. So the problem is that you need blood monitoring because the side effects like the drug effect of it takes time to act. So in leflunomide, methotrexate and sulfasalazine, you need to monitor the blood counts and the liver test. Patients are always worried about the creatinine, but creatinine problems usually occur mostly with non-steroidal anti-inflammatory drugs than with the conventional biological agents. Now everything has got revolutionized because we have targeted therapy. So we can prevent T cell activation, B cell activation. We can minimize systemic inflammation and synovial inflammation. So because we have the targeted therapy for all these drugs, our treatment is very, very effective. Patients with rheumatoid arthritis have scored gold medals in the Olympics. Even one of my patients is climbing Mount Everest with rheumatoid arthritis, right? So I am just telling you the level of good control with disease is makes anything possible. There are many doctors with rheumatoid arthritis, many medical students with rheumatoid arthritis, and if you treat this disease well, you can always win. you can achieve a complete drug-free remission only in a minority, but most people are happy to be able to do what they want as they want it. Okay. So how do you treat? You start with methotrexate, steroids, and anatomy protector medicine. You watch for 3 months, see if the drug target has been achieved. If it has been achieved, you continue the same treatment. If the drug level has not been achieved, you can try change in the dose, change in the route. You can add another conventional disease modifying drug or a biological agent. So these are the targets for rheumatoid arthritis treatment, and these slides will be shared with you. You don't need to worry about knowing the cutoffs, but all you need to know is there are disease activity scores. Using that, we can treat the patients. Okay? Sorry. So, in conclusion, rheumatoid arthritis is an inflammatory joint disease which affects the large and small joints of the body. If you have high titers of rheumatoid factor and high anti-CCP antibodies, you can confirm the diagnosis. If you have uncontrolled inflammation in the synovial lining, you get bone erosions, joint damage, and deformity. You need to treat early and have a narrow, because there's a very narrow window of opportunity to treat. The cornerstone of treatment is methotrexate, and you have a multidisciplinary approach to treating. Right. So, anybody has any questions? Yeah? Any questions to ask? Yeah.
Are there any behind pathophysiology for early morning stiffness? Like why?
Madam, as the rheumatoid factor levels doesn't change, just the
Right. Let me answer the first question. The question is why there is early morning stiffness. I'll come back to yours. When you have inflammation in the joint, it changes the internal milieu of the joints, and the viscosity of the joint fluid is changed, and you need lubrication for joint movement. And so when you get up in the morning, all these mediators are stagnant within the joint space. So you have to keep on moving till the thing spreads into your body, and then you feel the stiffness going away. So that is the answer for morning stiffness. But this is only a postulate. Nobody has proven it yet. The second question, I stopped halfway. What was the question? Sorry, I was on. Yes. There was a question about the rheumatoid factor. Someone asked a question about the rheumatoid factor. Please, can you repeat it? I am happy to answer it. Yes? Someone asked me a question. If you can't connect, you can just send me an SMS. Yeah? Was it Miss Gunawardana?
No, but I asked the first question. Thank you.
No, there was a second question. While you were asking it, there was a second question which I couldn't answer because I was answering your question. There was a question about rheumatoid factor, which was a very good question. I would like to answer that. Okay, any other questions? I think the question was, from what I heard, about rheumatoid factor and its fluctuation, and whether rheumatoid factor will be negative. This is what I heard, right? Because two people are speaking at the same time. Rheumatoid factor will be negative when you achieve a remission. That is not true. There is no point wasting your money to check the rheumatoid factor serially or the anti-CCP serially, because it doesn't change. Okay, you have to assess
can you hear
disease
me?
activity using combined joint scores, ESR, and CRP levels. Did I answer your question? I can see your face, but I don't have your name.
Madam, can you hear me now?
Yes, I can. I couldn't hear you earlier.
Yes, madam, I had a connectivity issue. That's why I got disconnected.
Yes.
Madam, as the rheumatoid factor doesn't change with treatments, likewise, the rheumatoid factor levels are those change with flare-ups, or
No, they don't.
they are
Thank you.
like
It's an excellent question. Lots of GPs keep on repeating the rheumatoid factor. It doesn't really change with flare-ups. Research has not shown that a value 3 times more is showing a flare, and a value 5 times more is showing a bigger flare. That has not been shown yet, and that's a really good question. But to diagnose rheumatoid arthritis, we think of levels more than 3 to 5 times the high normal reference range. Okay.
Okay, madam. Thank you, madam.
Thank you. Very good question. Any more questions? I'm happy to answer. I leave a little time so that we can discuss what was taught. But if you want me to re-show a slide or to re-explain a slide, I'm happy to do so. Any other questions? Why are there less people in the lectures? Is it only mine, or am I suddenly unpopular? Or are the students elsewhere?
Madam, this is the usual attendance because most of students having power cuts in this time, especially for
Okay.
hostels, madam.
Okay, I'm so sorry about that. Right, okay. Fine. So I will upload the recording anyways, but if there is any question to ask, I'm happy to answer. We still have a little time. Any question from osteoporosis, any question from rheumatoid arthritis, I am happy to answer. Please ask, because there are only a few of you, and it's a lovely number to do a lecture to. Yeah? Any more? Your next lecture is at 2:15, right?
No, madam, it will be at 3:30.
3:30?
Yeah.
In when? I could have done another lecture. I thought you had a 2:15 to 3:15 lecture.
No, madam, that lecture previously scheduled at 2:30, but as your lecture will be rescheduled to next week, that lecture shifted, madam.
Aparade, I wanted to shift one. Okay, so my lectures too have got shifted. I am very sorry about it. I am having a calendar clash. Okay, I will do your lectures as scheduled, and I will see you on Wednesday in person. Where is the lecture to be held?
Sorry, madam.
Your lecture, physical lecture, right? Finally?
Yeah, madam.
Okay, excellent. So I'll see you on Wednesday. If there are any questions, I am happy to answer. Okay. Okay. There is a question, a very good question. For me, this is from about osteoporosis. So the question is hormone replacement after menopause effective in the treatment of osteoporosis? Absolutely. It is very, very effective. But then there was a study, and I think people would have explained to you about the Women's Health Initiative, where a bunch of people were given hormone replacement therapy, and they had higher risk of thrombosis, higher risk of cancers, and because of that, hormone replacement after menopause is not advocated. But still, if you have really bad osteoporosis or really bad uh, um, menopausal symptoms, some people after counseling patients do give hormone replacement therapy. But standard of care is not to give hormone replacement therapy after menopause. Are there any other questions? Okay.
Madam,
So, yes, dear, please.
madam, about rheumatoid arthritis, is it more common among young females or elderly females?
It is a disease of young women, your age, and if you can call me young, my age. It is rare to come in older people beyond 65. It is it's essentially a diagnosis in young women and men. But there is a juvenile form of rheumatoid arthritis, which is there in children, and that is called juvenile idiopathic arthritis, and that is in people less than 16 years old. So even little kids can get rheumatoid arthritis. With the immunological diseases, what happens is your immune system has to be really active, and then your body is more susceptible to immunological diseases. So that's why it's commoner in young people. Did I answer your question?
Yes, madam. Thank you,
Okay.
madam.
Right. Are there any more? Okay. If there are no questions, I can end the lecture. But if there are any cancelled slots, let me know so that, but give me a little time so that I can prepare for the lecture. I don't want to just come without preparing. I'm happy. If I have a free slot, I will lecture for you because we are having parallel lectures for 3 modules. Sorry, 2 modules and a stream. So there is a bit of confusion and calendar clash for us. So if there is any free slot, can you send me an SMS about 24 hours before so that I can see if I can do one of the rescheduled lectures for you. Okay?
Okay, madam.
Right, because I am having the blood and lymphoreticular and the clinical sciences stream and too many things at the same time. Okay, right. Or then I'll see you on Wednesday. Good luck. Bye.
Thank you, madam.